You're listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We'll be joined by cancer experts to discuss blood cancer diagnosis, treatment, survivorship, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and a Blood Cancer United volunteer. And I want to thank all of you so much for joining us on this episode. Today, we're going to be talking about burnout, compassion fatigue, the differences between them, uncover the key components and risk factors for burnout, and share some practical strategies and resources to help healthcare professionals prevent, monitor, and manage these challenges. We're delighted to be joined by Chelsea Winiger, who is a licensed clinical social worker and manager of oncology services at Intermountain Health in Murray, Utah. Chelsea, thanks for joining us.
Thank you so much for having me, Dr. Miller. It really is an honor to be asked to even come and be a part of this. So thank you.
And thank you. I have a tremendous bias toward social workers because my middle daughter is one, a medical social worker. But I want to ask you, in terms of yourself, what got you interested in this topic?
I think a lot of healthcare professionals, as I've worked in the healthcare field and really just as a professional in general, I think I've really witnessed a lot of people who are really good at teaching self-care and talking about self-care to other people, but we're really terrible at receiving it. And we have to use that self-care, right, when we talk about burnout and compassion fatigue. And so I've been to a lot of different presentations about self-care and burnout and compassion fatigue. We've all been to them throughout our entire career.
You're
we
right.
go to them every year, and it's the same conversation every single time. And I don't know about anybody else, but I have often left those almost feeling a little defeated because I'm like, all of these strategies you guys talk about, I try to do, and they're not working.
Yeah,
They're
I
not
hear
helping.
you. Mm-hmm.
So that's really where that desire and passion for having these conversations has come from, is having a better conversation about the deeper self-care that we really need to talk about, because the wounds we accumulate in this work are so much deeper than I think we let on.
So, by the way, I'm nodding my head here. Yeah, and I'll tell you the part of the reason why I go to conferences, and typically you are correct. There's a seminar called Caring for the Caregiver, and I don't go. I sort of feel like I know what I'm going to hear already. Mm-hmm. So I totally agree with you on that. Let me ask you about, because I've been in this field for a very long time, what are the scars? I mean, I can picture it, but I want to know what your thoughts are.
Yeah. And I think we have our everyday scars that we talk about when we talk about burnout and when we talk about compassion fatigue, which I do think a lot of people mix those things up, or they think they're the same thing. And we know that they're different, right? Burnout is really this kind of, I had an oncology nurse once tell me that, I wake up really tired, and before my feet even hit the floor, I feel like I'm already behind. And I was like, okay, you're not talking about one traumatic event. You're talking about the relentlessness, that short staffing, that constant charting, that pressure to just take on one more patient, right? And when she took that week off and she came back and she's like, oh, I felt like myself again while I was on my vacation. That tells me that it's tied to the system, it's tied to the workload, it's tied to the environment. And it often lifts at least a little bit when you're able to step away from that. I think we don't go enough into the compassion fatigue, because the burnout feels a little bit easier to talk about because it's systemic. Compassion fatigue, right? One of my oncology social workers who comes to me and says, I supported this family through the end of life care with the husband, and now all I can think about and all I can see are those kids and that wife who no longer have their dad and their spouse, right?
Yep.
This person went on vacation and those images followed her. And she started feeling numb to other patients that were in this situation because she didn't want to feel that pain again. She avoided certain rooms or certain things, right? That's compassion fatigue. It's that emotional cost of caring. it's about the heart. It's not about the system. It's about our
Got it.
heart, that
Got it.
secondary trauma we absorb. And I think we avoid talking about that a little bit more because it's so vulnerable and it's so deep.
As you're saying that, what I'm thinking about that or maybe you or my colleagues, whatever, it's almost embarrassing a little bit to have compassion fatigue. I mean, compassion is part of what we do. It's part of who we are, at least how we see ourselves. It would be like being a parent and knowing a certain day you didn't really do a good job. You lost your patience, or it's almost embarrassing to talk about it. Does that have a part to play? Embarrassment or shame?
I think so, because I think there's this idea of this conspiracy of silence in healthcare, right? I'm not talking about the conspiracy of silence of staying silent when you're seeing something negligent happen, right? That's kind of what we usually talk about in conspiracy of silence. What
Right.
I'm talking about is that as helpers, we inadvertently are taught to be strong, to
Yes.
be composed, to be the helper. And so, what happens when the helper is not doing well, right?
True.
I think about that quote by Fred Rogers where he talks about where he was watching something scary on the news and his mom told him, look for the helpers. I tell this story to go along with it because it kind of shifted my way of thinking about this compassion fatigue. I had this nurse who came to me. We were in one of those weeks where you have a really high patient death rate.
Yeah.
It's one of
Yep.
those weeks it's like there's a lot of patients passing away.
Yep.
And quite a few of them were patients that we were really, really close with. Because let's just face it, there are some
Yes.
patients we're closer with than others. So it was
Absolutely.
really hard on the clinic. And so as a social worker, I was spending the week supporting the families as they lost their loved ones and supporting staff as they're trying to navigate the loss and the grief of losing these patients. And this nurse came into my office and she said, I really need to talk. And I said, okay, what's going on? Help me understand what's going on. And so she kind of talked about her experience and we talked and kind of gave her some ideas of things to do. And as she's walking out of my office, she's kind of holding the doorknob and she goes, Chelsea, I have to ask this question. I've watched you all week. You have spent all week helping everyone else.
Hmm.
And I can't help but think, who's helping the social worker?
Hmm.
And I obviously stammered because I've been a social worker for 16 years and no one has ever asked me that question. So I
Wow.
stammered
Wow.
over my response to her, right?
Yeah. Yeah.
And it made me think of Fred Rogers' quote. And now all I can think about anytime I hear that quote is, okay, but who's helping the helpers?
Yeah. Yeah. Yep.
Right? Because we're taught to kind of absorb these deeper wounds and just move on, right? Like your favorite patient passes away and you get maybe a minute before you have to go in and see your other patient.
Yeah. It's true. It's true. So let me ask you, I'll ask a personal question. Sometimes people ask me, so I'm going to ask you. I say, I'm an oncologist. They say, well, how do you do that work? So let me ask you that same question, but something else added to it. If you were doing a different job other than oncology, so let's really narrow it, would it be the same? I mean, can you picture yourself doing something different?
Yes, the first 12 years of my career were spent in child welfare.
Okay.
So I came from the child welfare world. And I will say, I don't think it's any different. I think when you're in a helping profession,
Yeah.
doesn't matter if you're working in cardiology, oncology, if you're working in the ED, if you're working in another profession, there are deep wounds that we experience as helpers that we don't talk about because we're the helpers.
Yeah.
We're
Yeah.
really good at giving care and we are terrible at receiving it.
Hmm.
Right? Which is what I would call kind of surface level coping skills that we always talk about, that we're always told to do. The reason that we never go to those self care presentations is because it's all the same, right? Do your mindfulness, take deep breaths, go for a walk, work out. And we leave them and we're like, well, I've been doing those things and I still am avoiding certain aspects of my work
Got it.
because it's
Right.
too hard, right? Because those things are great. I mean, we could spend all day, right, Dr. Miller, about how those turn on our parasympathetic nervous system. We can talk about the neural pathways that we're developing. And I'm super nerdy and I love talking about those things. We know why they work, but those things don't touch the grief that we carry. They don't touch the trauma that we witness. They don't touch the moral distress that we swallow or the expectations that we didn't meet, the patients that we still think about, right? If I'm burned out, a bubble bath will fix it for a few minutes, but it's not going to fix it forever because a bubble bath doesn't fix the system, right?
Correct. Yeah, yeah.
If I'm compassion fatigued, and this is why I hate when people tell me to take a deep breath, I'm like, no, that's not going to help
Yeah,
because
yeah.
the deep breath isn't going to process the trauma that I've absorbed as a helper.
So let's go back to one of the first things that we talked about, working with the EMR, having to do all the things that we have to do. It sounds like that's burnout. That leads to
Yes,
burnout. Okay.
that leads to burnout.
What are some strategies that meaningfully work for burnout?
Yeah. I think I would say one of the deeper ones that we don't talk about, right? Like, I mean, do the coping skills, right? They're good. I mean, they're great things to have. Like I said, they're important to have. I think one of the things we have to think about is what's within our control,
Mhm.
right? Because here's the deal, as helpers, we have kind of been taught that we're the fixers, we're the problem solvers, right? We walk into chaos and try to create order. We walk
Correct.
into
Yeah.
suffering and try to create comfort. It feels like our job and our duty is to control the uncontrollable. And somewhere along that line, I think we start believing that everything is our responsibility. The system, the outcomes, the emotions of our patients, the emotions of our families, the gaps in staffing, the broken processes, the impossible expectations of getting your documentation as soon as you're done meeting with that patient when you're already 30 minutes or an hour behind, right?
Yes. Yeah.
So, to me, what it comes down to, and I know this sounds so simple and cliche, but I think it's recognizing what is actually within our control, right? Because the truth is, we can't carry what was never ours to hold. So I had a clinician once tell me, he's like, Chelsea, I feel like I'm failing because I can't fix the system.
Yeah.
I
Yeah.
fix one problem, even if it's just EMR related, and it's like 10 more pop up, right?
Yeah. Yeah.
And I was like, well, you're not failing. You're just human. This system was not meant to be carried by one person.
You're
And
right.
so, really focusing on what's within your control. It doesn't mean that you stop caring, because I think as helpers, that's what we think. If I'm only focused on what's in my control, then I stop caring. It just means that you're not absorbing what isn't yours, right?
Got
So
it.
it's
Yeah.
asking ourselves, what's mine today? What's outside of my control, no matter how much I care? And what can I influence? And what do I need to release, right? Stephen Covey put together this really great circle of control. And it talks about what's within my control, what's within my circle of influence, and what's totally outside of my control. And so it might be taking a second to stop and think, okay, what is within my control, right? The only thing I can really control is making sure that my documentation is done as best a time as I can handle. And then what do I have influence over? What's totally outside of my control? And really focusing in on that control piece.
Yeah. It reminds me of, in a sense, saying choose your battles.
Mm-hmm.
And there is something pleasant as I'm listening to you about saying, you know what, I have some control over X, Y, or Z when it really comes to what's important to me, which is patient care and being with people. And you know what, I'm not going to choose the battle of fighting over the EMR because it's probably not going to move anywhere. Does
Right,
that
right.
sound
Yeah,
reasonable?
yeah, right. Because when we stop trying to control the uncontrollable, we are freeing up our energy to show up fully in places where we can make a difference,
Got it.
right? When
Got
I'm
it.
spending my time frustrated by the EMR and then I go in and I try to be present for my patient,
Yeah.
it's a lot harder. But when I kind of let go of some of that stuff that I can't control, then I can go into the space with my patient and be fully present and make the difference that I need to make for them.
All right, so let's move back with that in mind about burnout, which, by the way, as I'm listening to it, I'm feeling calmer. So I appreciate
Good.
it on a
Yeah.
personal level. But yeah, let's talk about compassion fatigue. First, and I'm particularly interested in not just the physicians, but the nurses, the social workers for that matter. What are the symptoms of compassion fatigue? What does it look like? And what are some of the risk factors, both between different people, why some may be more likely than others to experience it, and even within an individual, what puts someone at higher risk?
Yeah. I think as helpers, what you're going to see is that emotional exhaustion, right? You're kind of sitting in your car before your shift and you're like, I really don't know that I can do this today. Or it's that depersonalization where you're kind of catching yourself being cynical and it kind of scares you because that's really not who you are. Or it's that kind of reduction of personal accomplishment. You kind of start believing that nothing you do is enough. So why try? And so then you kind of become that cynical person that you're just there because you're getting a paycheck, right? You've kind of lost, logically, right? And you guys can't see me, but I'm pointing to my brain. Logically why you started doing this work, but you don't feel it anymore. You don't feel it in your heart anymore. That to me is someone who's really experiencing compassion fatigue.
Mhm.
And I think as we think about the risk factors, I mean, some of the risk factors are the same as burnout. It's the long hours, it's the short staffing, but you're also thinking about the moral distress that we experience every day, the feeling like we're carrying the weight of a broken system, that it all is our problem to fix. There's a lack of connection to the work that you do because you're trying so hard to just protect your own heart. And it doesn't feel like that, right? Because you're like, Chelsea, I can hear people already, no, I love what I do. I'm passionate about what I do. But let's be honest with ourselves. I mean, there are days that I come into work and I'm like, I can't do this today. I just lost one of my favorite patients and I don't want to do this again. I don't want to get close to another patient. I'm not going to get close to another patient, right? How many times have we said that? That's when compassion fatigue starts, when you leave and things don't get better. When you take the PTO and you still feel that pain and that hurt.
Occasionally, I'll ask a colleague nicely, saying, you're sort of not seeming like yourself. And almost invariably, people don't admit to that. They just don't. So I want to ask you, because honestly, truthfully, I think you get, as a social worker and as you, just I can tell who you are, I think, a caregiver. But I think maybe people level with you more than they do with me. So along those lines, if you had to estimate, let's talk about the whole pool of healthcare providers before we break it down into nurses, doctors, et cetera. But what's your guess as to a percentage of us who go through any given day with a sense of compassion fatigue? Is it high? Is it low?
I think it's higher than we say it is. And I think we don't, as professionals, and because we're helpers, I don't think we're as honest with ourselves as we need to be. Because as you stated earlier, it feels like it's a personal failure.
Yep.
And so there's a lot of times when I am working with professionals or I'm talking with healthcare professionals that I'm asking them, what are you holding that you've never said out loud?
Good question. And what do you hear? What do people tell you?
They're really heartbreaking answers, right? I still think about that patient from 3 years ago.
Well,
I feel guilty that I couldn't save this patient. And now these kids have to live without their parent.
yeah.
I'm not the clinician that I thought I would be when I graduated. I don't recognize myself anymore. If I'm being
Well,
fully honest with myself, I look in the mirror and I have no idea who I am. It's
yeah.
not the person I thought I was going to be.
Wow. Wow. And in what way, Chelsea? I'm not the person I thought I'd be. In what way?
Yeah, well, let me explain it this way from an experience that I had as I've kind of gone through my career. And it might not be a bad thing, right? When I graduated with my bachelor's degree in social work, I very much remember standing on the stage and so excited and so happy. I'm sitting there holding the fake diploma because they don't actually put your diploma in it, which is rude, by the way, right? But I'm sitting there holding that and I'm looking out at the audience and I'm like, I am so excited. I am going to change the world.
Mhm.
And as I've gone into my career, I had no idea that there was going to be so much red tape in trying to save the world.
Yeah, yeah, yeah,
And I can very much say that I look in the mirror and I am not that person from
yeah.
16 years ago. I am
Okay, yeah,
not. And that's not
yeah.
necessarily a bad thing,
Nope.
but there are definitely days that we look in the mirror and are like, I am not the compassionate person I was before. Right?
Yeah. I mean, I think that goes for all of us. And I will say, actually, one of the beauties of a longer career is that there's time to be slightly different in different parts of
Yes.
one's career or to do different things, essentially, as you've done. You've
Yeah.
had different parts of your career. So let's talk a little bit about maybe from a clinician's point of view, yourself in this environment. What are some strategies for monitoring healthcare professionals and providing support?
Yeah. And I think you hit on it just a minute ago when you talked about checking in on a colleague, right? When we kind of lay all this out, the emotional exhaustion that you experience, the cynicism that can kind of scare us a little bit, the feeling like nothing that we do matters, and you add on the burnout aspects, right? The long hours, short staffing, the systemic issues. I think we have to really look at these monitoring strategies a little bit differently. Organizationally, we all get the surveys.
Yes. Yeah.
How are you really doing? Let's do a survey to monitor how our staff is doing. And listen, I'm not saying that there's anything wrong with surveys and checklists. They are helpful, right? I will tell you the Pro QOL, it's a great tool to use, right? To kind of monitor burnout and compassion fatigue. But I think what's more important is monitoring. It's about leaders who are actually taking the time to notice when someone's spark is dimming. You can see
Yes.
it. You can see when it's dimming, but we're so scared to ask because we're afraid that we're going to offend them, right?
Yes.
And we know that some people are just not going to be truthful, right?
True. Yep. Yep.
It's about being the colleague who says, hey, you don't seem like yourself today. It's about creating spaces where people can cry after a hard case without feeling weak. There's this concept that I've talked a lot about when I talk with patients and staff and all of that is this idea behind felt safety. There's a difference between knowing that you're safe and feeling safe, right? Like there are people,
Yes.
I know they're not going to punch me in the face when I'm around them, but that doesn't mean that I necessarily feel safe around them. And I think that we have created environments in healthcare where the felt safety isn't there. And so people don't feel like they can actually be honest when we are monitoring it. When we do have leaders that come to us and say, I feel like your spark is dimming a little bit. Tell me what's going on, right? Because we're like, well, why ask? They're not going to tell me anyways. Well, we've just missed our chance of creating a level of safety for our employees. And so I think the best tool to monitor is paying attention, not getting so caught up in all the day-to-day things. Are you stopping and asking your MA, hey, how you doing today? Is there anything I can do for you?
Which is very nice, I have to say, because having been on both sides, I've not had a cancer diagnosis, but I've been through it with my family. So, how much of a difference the MAs and the nurses and the snack lady can make in a patient's experience. And I have to say, I like the word spark because I think who wouldn't want to feel like, oh, usually I have a spark. And Chelsea or Dr. Ken Miller recognize that. And it's not quite the same today.
Yeah.
Let me take it a little bit further. I love those words. I think they're really useful. What are some other approaches that you take, again, when you want to walk over to someone and say, gee, and in a sense, you have permission because you're a social worker and you're a psychosocial professional. But what are some other terms that may help someone open up as opposed to close down?
Yeah, you know what one of my favorite terms is, and I learned this from one of my mentor oncology social workers who I love and adore, is when I first started in oncology, she said, don't go into a room and ask, how are you doing? I mean, that's just kind of what we say, how are you doing, right?
How
But
are
there's
you?
like,
Yeah.
this patient is in an oncology clinic. How do you think they're doing? No one wants to be there. I mean, we love our patients, but I'm pretty sure we'd all love to work ourselves out of a job and not have people have cancer, right?
Yes, yes,
And so I've actually integrated the wording that she uses is, how are you holding up? That little shift is a very
yes.
different experience. And when I
Hmm.
say that to my colleagues, hey, how are you holding up today? It's not as easy to say, oh, it's good. I'm good.
That's right. Yeah,
You know,
yeah.
how are you holding up is a lot different of a question than how you doing? It's an intentional question.
Yeah, it is. And it actually begets a deeper answer, not a programmed answer. Oh, I'm fine.
Mhm.
Chelsea, I want to take advantage of this opportunity. What else? So we've come up with two things that I can use.
Yeah.
What else? Any other
Yeah.
strategies to really talk with people, colleagues?
I also think one of the strategies that I've used in terms of getting other people to share their experience is allowing myself to be vulnerable with them, right? It's going and saying, man, I'm having a really hard time with this patient that we just lost. And that opens up other people to be like, oh, it is okay to talk about this, right?
Yeah,
This is why I had other staff members that were in and out of my office because they knew that they would come in and that I would be willing to be vulnerable too, right?
yeah, yeah,
I always say that vulnerability breeds connection.
yeah,
I mean, think of the relationships that you have. The people that you trust the most and have the deepest relationships with are the people that you're most vulnerable with. And I think we've lost that type of connection in our society today because it feels scary, right? It's that felt safety. It feels scary. If I cry, I'm going to look weak.
yeah. And yet, crying with someone is, I mean, there's not only a catharsis for the caregiver, but to the person who walked in the room or to
Yeah.
the patient or to the family. I found, or I still find, but for family members are, especially those during a long hospitalization or a long illness, are somewhat forgotten. And honestly, just recognizing their presence. And now instead of saying, how are you doing? Saying, using the other words of how are you holding up is really a nice strategy. You work in a system, there's staff, there's not just one or two people. So, from a systems point of view, what are some of your thoughts on prevention and reduction in burnout and in compassion fatigue for that matter?
Yeah. Yeah. I think as an organization, obviously there's responsibility to have adequate staffing, to have reasonable workloads. I think we need to do a better job of managing up our leadership in helping them have better skills with social emotional learning, right? Helping them know that it's okay to sit down with staff and talk to them through these things and give them space to say, this really sucks and not fix it and
Yes,
just give
yes.
them the space, right? So I think we, at least in my experience, I think we need to do a better job of helping our leaders have better skills in those areas
Yep.
instead of just focusing on, oh, they're really good at finance. Oh, they're really good at the numbers and the data. And that's important stuff. I'm not saying, right, because that helps sometimes with adequate staffing and reasonable workloads. But I think we get so overly focused on that because it's easy. It doesn't feel so overwhelming that we need to do a better job of helping our leaders be more in tune with the emotions of staff and knowing how to navigate those experiences without just saying, here's EAP's number.
Yeah, you're right. You're absolutely right. Or take some time off or,
Yeah.
take a deep breath.
Hmm.
Yeah.
Hmm.
Yeah. There's not necessarily a correlation between leadership skills and psychosocial skills. I
Hmm.
mean, they're not at all mutually
No.
exclusive, but they don't necessarily go together.
Right.
I have to say, similar to yourself. I remember graduating and thinking, I'm going to go into academics. I'm going to help find a cure for cancer, which is what my mother was. She said, you need to find a cure. So anyways, with all that in mind, years later, I've helped fight the battle, but there's certain things I couldn't accomplish because there were other things. And I've heard you talk a little bit about the gap. So I'm interested in your thoughts on that.
Yeah. So when I was in my master's of social work program, I had this amazing professor and mentor who taught us this idea about grieving the gap. And it really has kind of shifted the way that I think about grief in general, right? We often associate grief with death, and we really kind of just talk about grief when it comes to death. And we could really spend an entire episode talking about grief we experience in our everyday lives, personally and professionally, that we never actually talk about. And that's where this grieving the gap comes in. This grieving the gap is this gap between expectations and reality. And listeners can't see my hands, but I have one of my hand representing expectations that's lower than my other hand representing reality. And there's a gap between my two hands. For example, I once had a doctor tell me, Chelsea, I thought I'd change the system, expectation. Now I'm just trying to survive it, reality, right?
Yeah. Yep.
That's a gap. And we do not acknowledge the grief that's in that.
Mm-hmm.
We grieve the professional we thought we would be when we graduated, just like I shared earlier and you shared,
Yep.
right?
Yep.
We grieve the system we hoped that we would work in and had to learn real quick that it's a lot
Yeah.
harder to work in it than it is.
Yeah.
We grieve this belief that compassion alone would be enough, right? That this expectation that people would just do the right thing because it was the right thing to do. And the reality is the answer we usually get is, well, show me the data,
Yes.
right?
Yes.
There's a
Well
gap
said.
between that.
Yep.
And that grief, because we don't talk about it, because we don't acknowledge that wound, it fuels burnout and compassion fatigue. And grieving that gap, it's not a weakness, it's honesty. And when
Mm-hmm.
we're honest with ourselves, then we can begin the healing process, right? And that's why I said those surface level, that deep breathing, mindfulness, it's not going to heal those deep wounds. And so when we can be honest with ourselves, then we can begin our healing process. We can allow ourselves to grieve things we never recognized were causing grief on top of the grief that we experience that's more obvious, right? The death of our patients, that kind of stuff.
Absolutely. Thank you. Very well said and very meaningful. So I appreciate it very much. Let me finally ask you about support resources for professionals.
Yeah. I think when we think about support resources, right, there we have the obvious. You have the EAP programs, peer support groups are always really great. I think there is, and this comes to that community care. Self-care is important. Community care also is. And I think peer support groups are really helpful in terms of recognizing that we're not alone in this work, right? That there are other people that experience what we're experiencing. We tell our patients with cancer to go to support groups because it's helpful for them to hear from others. It's the same thing for us, right? There's obviously workshops out there, and I'm not just saying our regular self-care workshops. I'm talking about things that are actually going to talk about trauma and working through trauma. So there's this book out there. This is the one thing that I think every professional to read is Trauma Stewardship. It is a fantastic book. The author of the book also did a TED Talk that is also really good to sit and listen to. But she talks a lot about the stuff that I've talked about, that we need to do more for ourselves as those in the healthcare profession and as helpers than just taking our deep breaths. And so that is a really, really good, I think that is one of the really easy places to start, is getting it on Audible, getting that book on Audible. If you're an actual book reader, get the book and just kind of start reading it. It's really, really helpful.
I have to say, as I've read books by other healthcare professionals, sort of about the work and about life, and it's actually that type of thing has been very healing for me because there's a sense of community to it. So thank you. Again, this is Dr. Ken Miller. I want to thank all of you for listening to this, not just informative episode, but Just incredibly interesting and wonderful episode to talk about really important topics. I particularly want to thank Chelsea Winiger, who is a LCSW and manager of oncology services at Intermountain Health in Murray, Utah. Chelsea, thanks again.
Thank you.
For a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, please visit bloodcancerunited.org/CE. And for any questions or to refer a patient to Blood Cancer United, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish. Blood Cancer United also provides other resources for patients, survivors, and their families, and this can be found at bloodcancerunited.org/support. And finally, I want to encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have suggestions for future episodes, please click the feedback button on this episode page. We look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archive section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with Blood Cancer United by following us on social media and access our healthcare professional continuing education activities by visiting bloodcancerunited.org/CE. Let's keep the conversation going. Until next time.